Documentation and coding. What could possibly go wrong? This brief presentation is about how your provider's documentation and coding department's performance can affect your facility's bottom line. My name is Ed O'Byrne, the Director of HM Revenue Integrity for Healthcare Resource Group, and as a former physician assistant and currently a coder and consultant, I've seen these issues from both sides, both as a PA creating documentation and as a coder creating the codes, and then finally as a consultant and auditor reviewing both sides of that coin. So how does that affect your bottom line? Well, theoretically, either PPS or other reimbursement schemes, a hospital is reimbursed directly or indirectly based on the quantity of resources expended on the care of each individual patient. Now, first, this relies on good documentation. If something is not documented, it didn't exist as far as this is concerned. Once we've got good documentation, the coding process is a translative process, turning that documentation words into alphanumeric ICD-10 codes. And based upon those codes and the various combinations, the payer pays based on the presumed resources reflected from those codes. So examples of how it can go wrong. Now, these are all real-world examples of problems in documentation and coding that my team has found at PPS hospitals and also critical access and other non-PPS hospitals where it matters, but the examples I'll show you here are for PPS hospitals and how it directly impacted the reimbursement for those hospitals. So these were discovered in real audits, sometimes as trends, sometimes as one-offs, but they always made a difference. For purposes of these examples, I'm using a kind of a generic 2017 DRG relative weights and base rate of about $6,000. That, of course, will vary by geographic area, labor cost, case mix index, and so forth for your particular hospital. Now, DRGs, I'll give you a super brief lesson, maybe a review for you on how DRGs work, so you'll understand how these coding and documentation opportunities had an influence on these hospitals' bottom line. DRG stands for Diagnosis-Related Group, and these are categories of diseases, conditions, and surgeries performed on each individual inpatient. They're typically body system related, and they are presumed by the statisticians at CMS to consume a similar amount of resources. Some of these patients consume more, some less, some are easy, some are hard, but in the end, the hospital gets paid on that DRG. To start with, arguably the most important element of inpatient coding is the principal diagnosis selection and sequencing. The principal diagnosis is that condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital for care, which sounds really easy, except that it's not. It's subject to a variety of rules and also to the coder's discretion. Oftentimes, many conditions will occur in any given patient, and it can be difficult to discern without guidance which of those diagnoses should be sequenced first. However, there can be a big difference in the hospital reimbursement based on that sequencing. I'll start with a couple of examples that illustrate how misapplication of coding rules can be misconstrued by coders and result in a large effect, a disadvantage in the reimbursement in the end. Sepsis is a very common infectious disease and is almost always coded as the first or principal diagnosis, but not always. A device complication is always sequenced as first. So a misunderstanding or misapplication of these rules can have a large effect on the coding, the resulting DRG, and the reimbursement. So a couple of examples of those. Sepsis due to a cystostomy tube coded with the sepsis as the principal diagnosis results in a certain DRG. However, correctly placing the complication of cystostomy tube as the principal diagnosis increases the reimbursement accordingly. Even an ordinary UTI due to a urinary catheter sequenced as such results in a certain DRG. However, the complication of that catheter which caused the UTI, sequenced first as it correctly should be, increases the reimbursement as it should. It gets really big when procedures are involved. A neurostimulator removal wherein the neurostimulator device was infected is a complication of that neurostimulator, and that should be sequenced first, which is a massive increase in the reimbursement. And that is a patient who would consume a lot of resources, stay longer in the hospital. Consequently, it makes sense that that reimbursement should be quite higher. How about the coder's discretion in selecting the principal diagnosis? This is probably the most common opportunity that we encounter, and it occurs most often in the multifactorial admission, a patient who presents to the hospital and is admitted for many problems all at once. Now, that's ultimately up to the coder's choice, and CMS and the coding guidelines allow and expect the DRG outcome to optimize the reimbursement for the care of the patient. Now, the Principal diagnosis sequencing follows some rules. Here's a couple of brief ones which are most salient to the point that I'm illustrating here. Interrelated conditions and conditions equally meeting the criteria for principal diagnosis. Coders, not being clinicians, oftentimes can't make this discernment. However, my team on reviewing these often can suggest a better principal diagnosis which is perfectly correct and does optimize the DRG and the reimbursement. Taking a hypothetical combination of pneumonia, COPD, heart failure, and respiratory failure in a patient, which is not unheard of at all, sequencing each of these in turn as the principal diagnosis results in a completely different reimbursement accordingly. And so, though sometimes it can be hard for the coder to discern, we've been able to help these clients figure out which of those was the correct principal diagnosis. Now on to CCs and MCCS. These are comorbidities and complications, and the MCC is the major version of those two. These increase the resource consumption, and it is said that 75% of the time the comorbidity or complication, a CC, will increase the length of stay by 1 day. That's sort of the benchmark that CMS uses. It may be said to be a bit arbitrary, but we just follow the rules. And of course, this increased length of stay and complexity increases the cost for the hospital and resource consumption, so that consequently the facility should be reimbursed greater. There's also an increased risk of morbidity and mortality. Therefore, the amount of tests and interventions that are provided is often higher. Here's an example of a trio of DRGs, and they tend to occur in sets of 3 for the common COPD in exacerbation without CC and MCC, with a CC, and with an MCC. So using a base rate of hypothetical $6,000, the hospital would be reimbursed without a CC $4,340, with a CC $5,510, and with a major comorbidity or complication $6,888. So there's a big difference as to the presence, proper documentation, the proper coding of those CCs and MCCs. Here's a list of some of the more common CCs and MCCs that occur, and it's not hard to imagine how these would cause a patient to be sicker and cause your hospital to spend more to take care of that patient. There are some subtleties with regards to the numerical values of some of these, and some of them are particularly up to the discretion of the physician to make it. Pressure ulcer stage 3 and 4 are MCCs, pressure ulcer stages 1 and 2 are not. So that's just where CMS has drawn the line. So speaking of whether comorbidity is present and documented at all, it's up to the physician to make the diagnosis and to correctly document that so that the coder can actually capture and translate it too. Let's take the example of the hypothetical patient in COPD exacerbation who may have an arterial oxygen level of 50, which by many criteria is chronic hypoxic respiratory failure. Many physicians consider that hypoxia to be implicit in the COPD disease process, but we found plenty of cases where the clinical criteria could be met, applied, and the diagnosis of chronic respiratory failure could be applied. And in this example, patient admitted with only COPD has a reimbursement of $4,420, but with chronic hypoxic respiratory failure, $5,439. That helps to compensate for the more resources that patient with profound hypoxia incur for the hospital caring for him. In this example, a condition as a comorbidity is documented, but without the adequate specificity to allow optimization of the coding and therefore the DRG. A patient admitted for primarily pneumonia, but also has heart failure, documented simply as having CHF, doesn't account for a CC at all. That is a certain fairly modest reimbursement. That same patient with congestive heart failure diagnosed with specificity, chronic systolic heart failure, which is the most common kind, does add a CC and changes the reimbursement completely. This may be due to a physician simply not knowing that it makes a difference to diagnose and document this with that specificity, but upon audits, we've often found that that specificity was evident in the clinical record. They just didn't make the final diagnosis. An acute exacerbation of heart failure, not surprisingly, more than doubles the reimbursement, but that's the kind of thing that's difficult but not impossible for a physician to fail to mention or a coder to catch. We have seen a couple of examples. An example of opioid or substance misuse of some scale, we find an example of the severity of that comorbidity not being documented with the correct specificity. Imagine a patient who was admitted for an abscess drainage after injecting heroin and had an opioid use disorder. Described as opioid abuse, This doesn't affect the surgical DRG that arises from the abscess drainage there. However, that same patient with opioid dependence does add a comorbidity that does change the DRG and hence the reimbursement. Physicians have expressed sometimes a reluctance to make what they perceive to be a psychiatric diagnosis, especially surgeons, but the criteria are actually fairly straightforward and easy for any physician or provider to make based on the patient's frequency of use and their dose, and more importantly, their risk of withdrawal. And it's that withdrawal that is likely to add the complexity, the length of stay, the increased risk of morbidity that costs your hospital more to take care of that patient. So this has been a matter of instilling confidence in the physicians for making the right diagnosis for each patient so the hospital is compensated correctly. Something I might call the subtle comorbidity that presents as a finding, lab finding, radiographic finding, that the physician either takes for granted or doesn't realize there's a code for it or a condition for it. Take the example of a subdural hematoma, which is bleeding in the cranium, when associated with a midline shift where the brain is compressed over to the other side of the skull. You can imagine the mere presence of the blood is bad, but the compression of the brain is much worse, and that mitigates the length of stay and the resource consumption for that patient. If correctly diagnosed and documented as such, this will be coded G93.5, and that's a major comorbidity or complication. It changes the DRG from 66 to 64 and adds $54.49 to the reimbursement. This is sometimes missed in the coding, and in a shared responsibility, sometimes it's a missed query opportunity where the coder should have recognized the radiographic finding through the radiologist's report and asked the attending physician if the patient had compression of the brain, and if so, please to document it so we can code it. The subtle CC as a manifestation in a related way, it may occur when a surgeon, for example, in the cases where we encountered it, felt as if the myelopathy was not a manifestation but simply part and parcel of the condition of spinal stenosis and failed to document it adequately many, many times over, causing the facility to lose many thousands of dollars over several years. This physician was performing spinal fusions for spinal stenosis, and many of the patients had symptoms and signs of cervical myelopathy, but it wasn't documented. As coders, in their defense, not being clinicians, weren't able to necessarily make that distinction to even recommend to the physician, but our team was able to recognize these, rectify it so the physician did add the diagnosis of cervical myelopathy when it was present, adding a CC and increasing the reimbursement accordingly. Conditions which resolve during the hospitalization, we found unfortunately that both physicians and coders can be guilty of causing an error in the ultimate coding and reimbursement in this arena. The coding guidelines always dictate that we code to the furthest extent of progression at any point during the hospitalization. And a common reason for hospitalization and a common manifestation of a stroke is hemiplegia. But fortunately, with good care, or sometimes spontaneously, it resolves on discharge. Now, where the physician can fall short is by not documenting in the discharge summary at all. It doesn't invalidate this as a codable diagnosis, but really it's a profound finding and should be documented all the way through the chart. Nonetheless, they may also document that it was resolved in the discharge summary, but the coder erroneously assumes that because it was gone by the time of discharge, they shouldn't code it. Either way, missing that hemiplegia diagnosis detracts $1,517 from the ordinary otherwise CVA code alone. So this is something we found that coders can habitually do over several years and just never get called on it until they do, and it adds up over the course of these very common hospitalizations for CVAs. The recent MI is an interesting case that requires some teamwork in the documentation and the coder. Now, acute myocardial infarctions by the ICD-10 standards last 4 weeks. That means that after they first occur, any other hospitalization during that 4 weeks, the patient still has the MI. They're still at risk of morbidity and mortality and other complications. For example, a patient who comes in for pneumonia and had an MI 3 weeks ago is still having those risks. Yet if the physician doesn't make mention of that MI clearly, as in the occurrence and the time of its occurrence, the coder cannot go outside that record to find evidence that the MI occurred. So it's really incumbent on the physician to document it and for the coder to understand that rule of how long an MI lasts so that they can code that MI correctly and add $3,530 to the pneumonia DRG. PCS Procedure Coding is the ICD-10 system for coding procedures, and some of the procedure codes do and some don't govern the DRG. PCS is extremely logical. I love it a lot, but it's very complex, so it's susceptible to misunderstandings in anatomy, surgical techniques, and coding rules by coders. Now, there are OR DRGs in which the procedure determines the DRG and the reimbursement, and there are non-OR DRGs. Spinal fusions are extremely popular these days, and they are especially prone to coder error and documentation pitfalls. Here's an example with a huge ramification for the reimbursement. That is the inadequately documented posterior fusion when done in addition to the anterior spinal fusion. I'll spare you all the anatomy there, except to say this example of documentation here does not describe the posterior fusion for which the patient consented and planned, but it's not in the operating report. So only the anterior fusion could be billed. Now, if it was documented correctly with the posterior fusion, the coder could have coded it correctly, and improving the DRG to the tune of $13,000. Now, this occurred in a particular facility where the coder was not very seasoned and was a little bit shy and failed for many months to call out the surgeon to correctly document until we audited this case and saw that it was just so close, but not quite, good enough to code. And then by going back in time and looking at several instances of this, we're able to recoup quite a bit of money for this facility. The PCS is built around several individual elements in the code itself, and one of those is the root operation. Some examples of those are resection, excision, bypass, replace, and there's 20-something more. The DRG effect on the root operation for any body system is variable, so those are some of the rules that could be misunderstood or misdocumented. A classic example is a subcutaneous debridement of a wound in which the method of the debridement completely changes the coding and the DRG. A non-excisional debridement counts as an extraction in PCS. That's a pulling out or off of tissue, and that doesn't affect the DRG at all. This DRG is based on cellulitis and reimburses at 7284. Whereas an excision is a cutting out of tissue, and excisional debridement, correctly documented, then governs the DRG as an OR procedure, reimbursing $10,579. There's quite a bit of difference. The approach is one of those other elements in the PCS code, and here are some examples that should look familiar. Open, percutaneous, endoscopic. Some of these are OR determining and some are non-OR DRGs. Let's take an example of a subcutaneous abscess drainage and how that abscess is gotten to by the surgeon and how the surgeon describes how they got to it. So an open approach is by exposure, that is cutting down to the problem and then draining this pus out. This counts as an OR procedure and it causes DRG of $581, reimbursement $7,000. Percutaneous through a small or needle incision isn't an OR procedure in DRG and has a completely different reimbursement here. So the distinction between exposing the operative site and causing a small incision to get to the operative site is incumbent on the surgeon to describe that very clearly as if the coder was looking over their shoulder and watching it happen. Can have a vast difference on the final reimbursement outcome. What I will call the PCS missed bedside procedures. Now, in lengthy inpatient records, sometimes these bedside procedures don't require a formal operative report, but they may be documented sparsely somewhere in a progress note or a handwritten procedure note, somewhere in the chart that's easy to miss. Sometimes not at all, unfortunately. So sometimes coders can miss these procedures and fail to code them. The DRG effect is variable. Many of these procedures don't affect it, but some do. So it's important that coders catch and code all physician-performed procedures, not nurses, physicians, and providers. Some examples of these so-called bedside procedures that can have an effect are debridements and excisions. These are actually quite commonly done, and depending on the extent, the body system, the root operation and approach, these can cause a change in the DRG. One profound example I found recently is a hemorrhoidectomy of a thrombosed hemorrhoid, which is not a complicated procedure. It can be done at the bedside, but lo and behold, that's an OR DRG, even if done at bedside, and that massively changed the DRG. Coders are very shy of using these DRGs 981, 2, and 3, as these are the OR procedure unrelated to principal diagnosis. Some of them are shy of the effects or fear that they're doing something wrong. Let me give you an example of how this can occur, and it's not super uncommon. A patient admitted for pneumonia has a certain principal diagnosis, which starts off their DRG. During their admission, they may have a cardiac arrhythmia recognized, and that's coded as a comorbidity or complication, and that requires implantation of an AICD. That then becomes the DRG driving procedure. This procedure has, however, nothing to do with the pneumonia, so the DRG is determined to be one of these unrelated to principal diagnosis. Now, the reimbursement is typically higher. It's not the sum of the two associated DRGs, but it's something higher than either of them. Accordingly, it's typically a target for payer audits, and that can make coders averse to considering these, and they'll tend to fudge the coding to avoid these OR DRGs, or these OR procedures unrelated to principal diagnosis. However, when they're right, and if they can be supported with the documentation and coding, the hospital is absolutely justified in claiming these DRGs. So with our help, we've added confidence to the coders in selecting the right codes and let the DRGs fall where they may. So these have been some examples that my team has found that have been very fruitful and gratifying to find for our clients, and illustrate some of the pitfalls that can be found in documentation and coding. If we can give your facility any help, we'll be glad to hear from you at the email address you see below. And this has been Ed O'Byrne from Healthcare Resource Group. Be well.